Good morning, Chairman and colleagues. I'm from Thammasat University, and today I'll be talking about a cadaveric study that establishes a safe zone in bicortical transhumeral biceps tenodesis. In general, biceps tenodesis can be broken down into two groups. One that uses the unicortical approach, and the other that is bicortical. Although the unicortical approach is more widely practiced, there are many disadvantages, as it is more likely to fracture due to the larger tunnel diameter, and it also cannot set the tension of the tendon. But the good thing about this approach is that there is no risks in harming posterior structures. On the other hand, the bicortical approach is a simple and quick process, similarly to the ACL reconstruction, and can be performed with a small tunnel diameter. Unfortunately, there is still not enough knowledge of posterior structures at risks, and there is still a controversy of where to pin the tendon. So to elaborate more about the tunnel diameter, in the unicortical approach, the drilled hole must be large enough to account for two ends of the tendon because the tendon is positioned as a U shape. This increases the risk of fractures, and there have been case reports of post-op humeral fractures that seem to have originated from the tenodesis site. However, for the bicortical approach, the tendon can be easily passed through the humerus with a small diameter. Another issue with the unicortical approach is that tension cannot be controlled, as the tendon is fixed in place arthroscopically. But for the bicortical approach, tension can be modified by hand so that it is optimal prior to fixation. So from all the pros and cons, what is left to discuss about is the posterior structures at risk in bicortical approach and to give a suggestion of a good tenodesis site. There have been previous studies that explore similar topics. This one advises surgeons to pin the tendon at the inferior aspect of the bicipital groove because it is farthest from the axillary and radial nerve. However, there are some limitations to this study. First of all, the sample size is small and it does not represent the Asian population, and the safe area concluded in the study is established in the form of a safe point as opposed to a safe zone. And according to the study, an error of less than 4 degrees can be expected when drilling at 90 degrees, which is a disadvantage as it does not account for this error. Lastly, it is difficult to locate the inferior aspect of the bicipital groove from surface anatomy. So for my paper, I have decided to choose the proximal end of the bicipital groove as a reference point because it can be easily identified between the greater and lesser tubercle. In my study, the sample size will be 20 shoulders and all the cadavers will be Thai so that it represents the Asian population. And I would also establish a safe zone, which would include both the center and its borders, so drilling at the center accounts for a certain amount of error. As mentioned previously, these are the objectives of the study. The subjects in this study are fresh frozen cadaveric shoulders with a sample size of 20, and the baseline characteristics are as follows. Next is the method used in the study. The skin was incised and the structures at risk were identified, which were the axillary nerve, the radial nerve, the articular surfaces of the humeral head, and the cephalic vein. Here is a diagram showing the general location of each structures in relation to the humerus and the pectoralis major. This is the cephalic vein running anteriorly across the pectoralis major. This is the cartilage, and this is the axillary nerve. And this is the radial nerve. After identifying all the structures, the cadaveric shoulders were positioned properly for bicortical drilling, which was flexion 90 degrees, internal rotation 30 degrees, and abduction 30 degrees. Next, the humerus was drilled perpendicularly at 4 places: the proximal end of the bicipital groove, the middle of the bicipital groove, and the upper and the lower border of the pectoralis major insertions. So the humerus was drilled in 4 places like this. This is an image that concludes all the structures and pins all together. Then the measurement process was next. We had 2 assessors using a digital caliper to measure the displacement from the structures to the nearest pin. The statistics used includes the intra-class correlation to evaluate the inter-observer reliability. So from the raw measurements, they were put into these categories depending on the relation to the nearest pin. For the axillary nerve, 20% is superior to the upper border of the pectoralis major, which is seen in this image. And for the posterior articular surface, 45% of them are inferior to the pin at the proximal end of the bicipital groove, which means that the pin penetrates through the articular surface, which is shown in this picture. This repetitive process was done for all structures and pins. So we concluded a scaled diagram that summarizes everything. As you can see here, the posterior cartilage can extend from here to here, which is below the pin. The location of the axillary nerve ranges from here to here. So just by looking at this image, the safe zone would lie around here, which is highlighted as the green box. So the next question is, where exactly is this box? If the entrance and exit pins perfectly correspond with each other, the end result is that the center of the safe zone lies 18 millimeters inferior to the proximal end of the bicipital groove. The superior border of the zone lies the posterior articular surface, and the inferior border lies the axillary nerve. Therefore, the zone boundaries are around 9.4 millimeters superiorly and inferiorly. Next, I will be discussing the limitations of this study. There are 5 concerns in total, which I will explain one by one. The first one is the assumption that the entrance and exit pins are perfectly aligned. The structures and measurements are done posteriorly, but the safe zone has to be established anteriorly. So a condition must be made in order to correlate the data together, but in reality, there will be a certain amount of drilling error. Another issue is the precision of the landmark. The mean value of 18 millimeters has a large standard deviation of 4 SDs. However, the zone is still valid because although there is a wide range of values, they do not exceed the safe zone. The next limitation is the difficulty in determining the appropriate proximity of the zone boundaries, as there is no previous literature on how to establish safe zones in regards to avoiding vital structures. Another limitation is that we did not assess the rotator cuff injury because the beath pin is very small in comparison to cuff muscles and would not cause any complications. And lastly, in contrast to other structures, the cephalic vein was most mobile. To minimize displacing the vein, the deltoid split approach was used as opposed to deltopectoral, and all equipment that may cause any tension were removed prior to measuring. In clinical practice, bicortical transhumeral drilling can be performed at the safe zone, and the biceps tendon can be pinned arthroscopically. So for the take-home message, this cadaveric study advises surgeons to drill bicortically at 18 millimeters below the proximal end of the bicipital groove. The safe zone provides a room for error and reassures that posterior structures will not be harmed. Thank you for listening to the presentation. You are all welcome to the TOSM APCAS meeting in Pattaya, Thailand in the year 2020.